I start to share my screen, and I would like also to thank the NeoBiotech company for his kind invitation for this evening webinar. And first of all, let me thank everybody who is connected with us. I hope that you are safe, that you are in peace, and I hope that this COVID-19 disease will decrease all over the world. So maybe next time we will meet again live, not with the virtual webinar. This evening, we will talk about how and when we have to manage the soft tissue in the aesthetic area. And I know that all of you are aware about the implant solution and how which is the clinical efficacy of the dental implants. I think that everybody agrees with me that if you are able to perform a correct implant treatment, the implant treatment itself will be predictable following the conventional implant surgery in terms of survival. And after 20 years, probably you will have a clinical result like the one that you can see on the left of the screen. But I think also that everybody will agree with me that if we want to obtain this kind of result, we need to follow guidelines for the supportive therapy. The supportive therapy is very important, as Margareta Allin and Björn Klingen from the Karolinska Institute in Sweden have already demonstrated about 15 years ago. So in my office, I have a very intense supportive therapy for the patients who are rehabilitated with dental implants. And if you are able to create this kind of supportive therapy, probably you will have this kind of result at a 10 years follow-up, a cumulative success rate of 97–92%, and only 7% of the implant with peri-implantitis or with problem related to this kind of disease. But we must remember that the supportive therapy is not the key factor probably in this kind of result. One of the most important, probably the most important key factor is the presence of a keratinized mucosa. The keratinized mucosa it consists of a dense collagen-rich connective tissue, and it is covered by keratinized epithelium. Around the implant, the keratinized mucosa extends from the soft tissue margin to the mucogingival junction. So it will include the free and the attached mucosa. Why it is so important? Because in our clinical experience, but also in the literature, if you take a look to the several studies that are published about these arguments, you will easily notice that the plaque accumulation, the gingival inflammation, the soft tissue resorption, the loss of support bone, and probably the peri-implantitis itself are strictly related to the presence or to the absence of this kind of mucosa. So if we want to have a good result, a nice result, not only from a clinical point of view, but also from aesthetic point of view, for a single implant supported prosthesis, probably you need the presence of at least 2 millimeters of keratinized mucosa. But not only for a single implant, but also for a multiple implant rehabilitation. as you can see in this case, with 20 years follow-up, the presence of a good amount of keratinized mucosa has played a very important role in the maintenance and in the aesthetic final result. The keratinized mucosa is also important from the patient point of view, because the patient, the dream of the patient is to have a crown over the implant, which is more or less similar or identical to the natural tooth. So they take care about the keratinized mucosa, because the patient are able to analyze if you have a good aesthetic result, a nice aesthetic result or not at the end of your oral rehabilitation. And one of the key factors is related to the presence or to the absence of the keratinized mucosa around the implant. We have the possibility now to analyze from an aesthetic point of view the final result of our rehabilitation. One of the index is the implant crown aesthetic index that was published around 15 years ago by Mayer. And with this kind of index, it will be possible for you to analyze the aesthetic final result. But probably the most simple index is the pink aesthetic score, published by Furhauser 15 years ago, where you can analyze the aesthetic final result that you have delivered to the patient, analyzing 7 different points. So the presence of the mesial and the distal papilla, the soft tissue level, soft tissue contour, and so on. Finally, the soft tissue texture. By the using of this kind of index, it will be easy for you to understand which is the level of your final rehabilitation from an aesthetic point of view. So it will be easy for you to understand that probably a rehabilitation like this will be not such aesthetic as you imagine, because we do not have the papilla, we have the presence of soft tissue shrinkage on the central incisor. So it will be easy for you, but it will be more easy also for the patient to analyze it, to understand if this is a nice aesthetic result or not. So if we are discussing about the presence, if you are discussing about the presence of 2 millimeters of keratinized mucosa around our implant, and if we take a look to the literature, we can see that part of the literature consider indispensable the presence of a keratinized mucosa for an aesthetic final result, and also for the supportive therapy, so for the maintenance of the quality and the level of the implants year by year. On the other hand, you can see that some study in the literature consider that the 2 millimeters of keratinized mucosa are not needed around the implant. Starting with the study of Benstrom in 1994, and finishing with the study that I present here on the right, which was performed by Christoph Armerle and Daniel Thoma, that are probably two opinion leaders regarding the implant prosthesis and the implant surgery. And they consider that the width of keratinized mucosa may not be crucial to maintain peri-implant health in complaint patient. This is very important, because if you have complaint patient, probably for the maintenance of the patient, this kind of mucosa, it is not so necessary. But also if you have complaining patient with after 10 years follow-up, which from a clinical point of view, which kind of the situation you prefer for your patient. We have a central incisor with an implant in the right side, the right central incisor, no keratinized mucosa, a small recession, and here on the other image on the left, we have a left upper central incisor over the implant with a good amount of keratinized mucosa. So the question is, which kind of situation you prefer from a clinical point of view? Which kind of situation will prefer probably the patient? I am sure that you agree with me that we prefer the clinical situation on the right. A friend of mine, always speaking about this topic, says that keratinized mucosa is like money, better if you have it. Why? Because it facilitates the oral hygiene for the patient. It will cover the gray color of the implant, and this is last but not least, because probably is the most important key factor, will give to your prosthesis a better emergency profile. But the keratinized mucosa itself is not sufficient, because we can have a situation like those where we have a great amount of keratinized mucosa, but we have good crowns, good aesthetic crowns, good ceramic crowns over the implant, but we do not have aesthetic. Why? Because the keratinized mucosa is not itself sufficient to create aesthetic in this kind of patient. And probably the most important key factor to have a good aesthetic result is the bucco-palatal position of the implant, as Ignacio Sanz Martin has already published this year. So, which are the factors that are able to influence the width of keratinized mucosa around dental implants, now that I have explained that we want this kind of mucosa around our implants? First of all, we must remember that always the implants located in the maxilla have a higher level of keratinized mucosa than those in the mandible. We must remember that we have the same situation in the natural teeth, as was demonstrated by Langer and Lowe in the late 70s. Then we can have a lack of keratinized mucosa if we are in front of a periodontitis. If we don't have an adequate amount of bone, please keep in mind this factor, because we will discuss about the amount of bone later on. We will not have probably a good keratinized mucosa if we will perform simple or complex procedure of bone augmentation. And probably we will lose keratinized mucosa if we make some errors in our flap design, in our incision, and particularly in the flap insertion, as I have already said. So if we want to eliminate the iatrogenic error, we must once again stress the point of the patient analysis. You must study the case in detail in order to be able to insert the implant in the correct position and be able to create a correct surgical stent and a correct provisional restoration over the implant. But if you want to have soft tissue in a very good condition, like the ones that you can see in this image or in this image, you must remember that you need bone. What it means? It means that we need to augment the bone in a great number of cases, especially if we are dealing with a delayed implant insertion, if we are not performing an immediate implant insertion. So if we want, to have good aesthetic, we need to recreate the bone, and in this case, if you are able to recreate the bone, you will have a good final aesthetic result. So we need to deal with different materials. We need to deal with membranes. We need to deal with biomaterials if you are not using autologous bone. And speaking about the membrane, we can have resorbable membrane, non-resorbable membrane, such as the titanium mesh, which I consider a kind of membrane, and we can deal with tissue matrix, and we will speak about these topics later on. If we are dealing with the resorbable membrane, we will have two kinds of resorbable membrane: the cross-linked membrane and the non-cross-linked membrane. I use the cross-linked membrane when I need membrane that will resorb in a long-term follow-up. Long-term means more than 3 months. So when I have to augment the bone around the implant, as you can see here, we have a bone defect. I need to augment the bone. In this case, I need to use a resorbable membrane, which is a cross-linked one. So I needed to fix the member over the biomaterials to obtain a bone augmentation, and especially to obtain a good soft tissue contour, an amount of at least 2 millimeters of keratinized mucosa. So in this case, I will have a good emergency profile, so it will be easy for me, it will be easy for you to take an impression and to create a final prosthesis, which will be a screwed prosthesis with a good aesthetic contour, emergency profile that you can see in this image from the occlusal point of view, but also from the lateral point of view. Otherwise, if you want only to augment the bone, but to give a support to the soft tissue, to have a better aesthetic, not around the implant, to increase the bone around the implant, you can utilize, in this case, a not cross-linked membrane, which will resorb probably in less than 3 months, but that will be enough for you to recreate a good aesthetic contour from, once again, from the occlusal point of view, but also from the lateral point of view. Sometimes you must deal with non-resolvable membrane when you have a huge defect, a vertical and a horizontal defect. And some years ago, I consider about 15, 20 years ago, we were dealing with non-resorbable membrane. And with this kind of membrane, we were able to obtain a good aesthetic result. Now, we can utilize the titanium mesh because they are easier to sagomate around the implant. So in a case like this, where I don't want to perform an immediate implant because I have a fracture, I don't have a good soft tissue contour, I have here a fistula, I prefer to deal with a delayed approach. But now my surgery at this moment usually are immediate loading approach surgery. When I have to deal with a bone regeneration like this, it is not so usual now, but I prefer to utilize titanium mesh. So you can insert the bone, insert the autologous bone and fix the titanium mesh over the implant. And you can see here that when we perform also only a very small augmentation like this, we lose something in the soft tissue. So we will see later on that in this case we have to recreate the soft tissue contour. So we remove a T-mesh, we take an impression, we insert a provisional restoration, and after 9 months we are ready for the final rehabilitation, for the final crown. So now that we are in 2020, we must remember the teaching of Garber of the last century. The bone sets the tone, but the tissue is the issue. I have already said that you need the bone to have good emergency profile, but as we can see later on, we need to have good soft tissue contour. We need to increase the soft tissue contour to have a good final aesthetics. We must remember that in clinical practice, it is not always possible to recreate the soft tissue. Why? Let's take a look to this case. This is a lady in Italy, and sometimes is not, we had to extract the tooth in the frontal area, and the patient asked us to obtain a good smile, a good aesthetic result, a good smile result at the end of rehabilitation. But we have to deal with different problems. This is a very demanding case from a surgical point of view. The patient is not an ideal patient from the bad general health of the patient. She is not in good condition in spite of his youngness, because she takes biphosphonate. She doesn't want to go under very complex surgery procedure. And last but not least, she has no enough money to undergo this kind of procedure. So we must consider other kind of situation, and we think about the teaching of Kochman and about the possibility to have a ceramic soft tissue contours. This is one of the chances that we have in this patient. And we can create a good smile, a good aesthetic result using ceramic to recreate the soft tissue around the dental implants. So the patient will be probably, is probably very happy, and she had once again a good result from an aesthetic point of view without very complex surgery. Sometimes we are not in the possibility to recreate the ideal soft tissue contour. This was the situation of a lady of 80 years old. She has performed some immediate implant in another office, and the doctor at the end of the surgery said to the patient that she must keep the implant for the future, because in this situation it was not possible to realize a fixed prosthesis. And so she has to keep a removable prosthesis. So she came to my office and she asked me, please doctor, give me a fixed solution. After that, I make the re-entry. It was easy for me to understand why the first doctor said to add that it was impossible to recreate, to create a fixed prosthesis. Why? Because the implant has been inserted with a complete wrong angulation, in a complete wrong position. So the only possibility for us was to create a screwed restoration once again with a soft tissue contour made by ceramic. But you can see here that the implants are not inserted in good position. We have a recession. We do not have 2 millimeter, at least 1 millimeter, half millimeter of keratinized mucosa. Obviously, the patient was happy about the result, but we know that in this case, we must keep the patient under strict control with the support therapy, because the lack of keratinized mucosa is very dangerous for us. So if you want to have a good result around your implant, you must keep in mind that, as I have already said, you have to insert the implant in the correct way. You have to manage in the correct way the soft and the hard tissue. So in my opinion, the easiest way to obtain good soft and hard tissue around the implants is to maintain and improve what you have at the beginning. So to perform an immediate post-extractive implant with an immediate loading. This is a case of a Monday morning. The patient went in the office with a fracture of this root, and she said to me, "Please, doctor, help me. It's impossible for me to stay without the central incisor." Please remember that now we have the face mask, and it's easier for us to treat this kind of patient. But at 10 years, 20 years ago, it was not so easy to deal with the central incisor. So I insert the implant, I utilize the old crown of the patient as a provisional. I perform the soft tissue graft, connective tissue graft from the palate, and the insertion of the heterologous bone. And after 9 months, we had this result. And it has been possible for me to maintain this kind of result also after 20 years with a good final aesthetic result. But if you take a look to the literature, you will find that there is a branch of the literature that consider impossible to obtain good aesthetic result if you perform an immediate implant. They consider possible to obtain an aesthetic result only with delayed implant. But once again, if you take a deep look inside the literature, obviously you can find studies that demonstrate that also with an immediate implant, you can have a good aesthetic, a final result. And I believe that we are dealing only with two different treatment philosophies. On the left side, when you are dealing with delayed implant, you have to recreate what was there. Obviously, you can do this, but it is more tricky, in my opinion. On the other side, if you perform immediate implant, it will be easy for you to preserve what is there and to obtain a good final result. In July, we have already discussed about this topic in a previous webinar, and we have already analyzed which are the key factors that are able to influence from an aesthetic point of view the final result. So I will not stress again the point with this situation, but we have already discussed about marginal level, about tissue, about bone, implant position, biotype, conversion, which is very important, which is probably one of the most important key factors together with the implant position. Because we have learned from the study of Uli Grunder 20 years ago, the importance of the connective tissue graft. And Kobayashi this year stressed once again the fact that with a connective tissue graft, we will have less resorption, labial bone resorption, we will have less recession. And we have already discussed in July about the abutment design and about the soft tissue stability with this kind of design. So I think that now is clear for everybody, for everyone, how you have to deal and to manage to obtain a good aesthetic result, not only for a single crown, but also for an immediate multiple crown, an immediate bridge, as you can see in this case. If you deal with the topics that we have already discussed, you will have a good amount of keratinized mucosa around the implant and you will have a good final result. If you take care to all the points that I have stressed, you will be able to manage also very difficult case, very challenging case like this, where we have to extract the central incisor for the presence of periodontal problem, a great periodontal problem. So today it is easy to manage this case with the use of the intraoral scan and by the use of a digital technique. It's possible to extract the tooth, to create a digital wax-up, and to bring this digital wax-up into the guided surgery planning system. So it will be easy for you to obtain a guide, a surgical guide, to insert the implant in a very straight position, in the very correct position, and to create a provisional just before the surgery. So the day of the surgery will be easy for you to manage the soft tissue, to insert the implant, to insert the bone, the artificial bone, the dermal matrix. We will discuss about these facts, and to screw on the prosthesis. And after 1 week from the surgery, the final result will be probably not the final, the provisional result will be like the one that you can see on the right. But obviously, not always you can perform the post-extractive immediate implants. Sometimes you are obliged to perform a delayed approach. And in this case, we must remember how we can improve the quality of the soft tissue. We have different techniques that we can utilize to improve the quality of the soft tissue. And if you go once again inside the literature, you can see which is the efficacy of one technique instead of the other. But if we have a good aesthetic situation, if you have a good amount of keratinized mucosa, as you can see here, so probably in this case, we had not to perform a GBR prosthesis, it will be easy for us to do only a crestal incision to obtain a good aesthetic result. But normally, you have to perform an apically positioned half thickness flap, because as you can see in the initial situation here, if we perform a GBR around the implant, we need to improve the width of a keratinized mucosa, so we need to improve the soft tissue to obtain a good emergency profile, a good aesthetic profile. And also with the second stage surgery, if you are performing a delayed approach, you can use a connective tissue graft. But now, or you can use a dermal matrix instead of the connective tissue graft, as in this case. But we will discuss about the dermal matrix later on. But now the question is, when we can improve the quality of the soft tissue. You can improve the quality of the soft tissue before the implant surgery if you are dealing with a socket preservation technique. I don't like this kind of procedure, so I have utilized this kind of procedure only in few situations in my clinical practice. But if you want, you can try to improve the quality of the soft tissue before the implant surgery by using a full thickness graft or by using a connective tissue graft or a dermal matrix. Normally, and not normally, but usually, you can perform the improving of the soft tissue during the implant surgery. This is what I do also for the immediate implant, because I prefer always to improve the quantity of soft tissue by using connective tissue graft or dermal matrix during the surgery. Or you can improve the quality of the soft tissue after the implant surgery. And this is what happens more often if you are dealing with a delayed implant. So if you are dealing with a delayed approach, you have probably to improve the soft tissue by using a connective tissue graft, once again, a dermal matrix, or an apically positioned flap. But do we have any new techniques, any new technology, or a new material that we can utilize to improve the quality of our soft tissue? The first technique that I want to present to you is the socket shield technique that was published around 2010 by Urzler and Otto Zur. And I think that everybody have heard about this kind of technique. With this kind of technique, you have to maintain a very thin layer of the root, as you can see also in the cone beam CT and then in the CBCT, in this image of this study, where they compare the socket shield technique with the conventional immediate implant placement with immediate temporization. And the result of this kind of technique seems to be very promising. And I know that a lot of clinicians use this kind of technique in their daily practice. I really don't like very much this kind of technique because I don't like to leave a part of the root near my implant. I think that this kind of procedure will be good in a patient like this. This is a very old patient. She is 26 years old, and I don't want to work a lot to remove all the root. I am worried about the possibility to fracture completely the wall of my buccal bone. So in this case, I consider this kind of technique, but usually I really don't like very much. But I know that the socket shield techniques works very well. You can see here a good amount of soft tissue, a good amount of keratinized mucosa. Another interesting technology that probably you can utilize in this case, as I do in my case, is the magnetic mallet. I know that probably every one of you has already heard about this kind of instrument. It is a sort of osteotome that is very useful to extract the tooth, to extract the root, but also to prepare the future site of the implant instead of drilling. In this case, will be more simple than the drill to insert the implant in the right position, because you can control with the hand this kind of instrument, and it will be very easy for you to insert the implant exactly in the position that you have planned. So it will be very easy at the end of the prosthesis to have a situation like this, to have a good amount of keratinized mucosa, because you have planned everything very well, and you have inserted the implant in the correct position. Talking about the materials, we must talk about the dermal matrix, the tissue matrix. This is a very interesting key point, a very interesting emerging material that we can utilize in our rehabilitation. We know that in the literature there are a lot of studies about this material, and it was presented more or less 10 years ago as a material created by the porcine or by the human, or from the human, like this membrane. In Italy, but I think in all Europe, we have some problem to utilize product from human body. So this product is not available anymore in Italy, and we have only the porcine one. And as I told you before, we started to utilize this kind of material more or less 10 years ago. And the comparing study between different technique like the porcine dermal matrix versus, for example, the tenting screw, the situation where you perform a submerged implant under the cover screw, demonstrate that you can reach a very high level of thickness by using the dermal matrix. But if you go into the literature, you will see a lot of study about this fact. As I told you before, I started to utilize this kind of material more or less 10 years ago. And after 10 years, I have very interesting result, very nice result. So I can say that this kind of material works very well, and probably in future you can utilize this kind of material instead of the connective tissue. Normally, I prefer to use this kind of material when the patient does not allow me to harvest some soft tissue from the retromolar, from the tuberosity, from the retromolar area, upper retromolar area, or from the palate. But I think that in future we will use this kind of material more frequently than now, especially because I will show you a new product which is a real connective tissue rich of also of proteins from the porcine that works very well. In this case, I had to extract the central incisor, and as always, I perform an immediate implant with an heterologous bone, and here with a dermal matrix, because the patient does not allow me to harvest some connective tissue from the palate. Once again, the provisional, I know that everybody knows this procedure now, and this is the situation after 1 year. A good soft tissue contour, a good soft tissue amount, keratinized mucosa amount, so we are ready for the final restoration. But as I told you before, now I am dealing with this kind of material, which is not like a membrane, not like a data-treated membrane, but it is real connective tissue from the porcine. Obviously, it is treated in a way that you will not have problems of antigenic response, of infection. It is a material that was widely used in the cosmetic surgery, in the aesthetic surgery, and now they have prepared it in a very small layer that you can utilize in the mouth, not only for a cosmetic surgery or an aesthetic surgery in the body. I try and I prefer to utilize this kind of technique when, once again, when the patient does not allow me to harvest soft tissue from the palate instead of a dermal matrix. In this, I come back a moment. In this case, we had to extract these two central and lateral incisor because it was not possible to retrieve them, and because of the situation in the mouth, the aesthetic situation in the mouth of these two roots. So we planned the extraction of a tooth, we planned the provisional restoration, and we perform the surgery, which is similar to the ones that you have already seen before, but the only difference is that instead of the connective tissue harvest from the patient, instead of the dermal matrix, I utilize the connective tissue, the real connective tissue from the porcine, as you can see here. This was the situation just after the surgery, and this was the situation 10 days after the surgery at the suture removal. This kind of connective tissue, like the connective tissue harvested from the patient, is possible to utilize this kind of material, this kind of tissue, to perform a GBR in the patient. If you take a look into the literature, you can see that a group of clinicians are utilizing the connective tissue instead of a membrane. So now the question is, are we going to perform a GBR itself with a resorbable membrane, with a non-resorbable membrane, or we perform a GBR with a connective tissue? We must remember that if we perform a GBR with a resorbable membrane, especially in the post-extractive implant, you might have a situation where you lose all the buccal bone, and your implant, after 7 or 10 years, as was demonstrated by Benich 7, after 7 here, you can have a situation like this. After 10, 7, or 10 here, you can have a good function of the implant, a good aesthetic of the crown, but you can see under the mucosa, not only under the soft mucosa, but also under the keratinized mucosa, you can see the xenograft material, which completely surround the implant. So for this reason, it is very important to perform always a connective tissue graft or a graft with a connective tissue substitute, a dermal matrix. But if you perform this regeneration only with the connective tissue, you might understand that probably it is not sufficient, it is not enough. So the answer to the question that I made just before is probably that you have to perform both the situation. You have to perform the GBR, so you need to insert the heterologous bone around the implant if you are dealing with a post-extractive implant. but you need also the connective tissue graft. So let me conclude with this case where unfortunately, I had to extract the the central incisor, the left central incisor, due to a root fracture during a soccer game of this patient. So we extract the tooth, we insert the implant, we insert the bone around the implant, and we harvest some connective tissue from the tuberosity, and we insert the connective tissue into the around the implant to improve the soft tissue. And this was the situation with the the provisional, and on the right, the soft tissue 1 year after the final rehabilitation, where from going back to the initial pink aesthetic score, you can see that we have a good mesial papilla, a good distal papilla, that we have a good soft tissue quality, a good soft tissue amount, and soft tissue contour. So always, please remember that when you are dealing with aesthetic case, it is not enough to increase the bone. You have also to increase the soft tissue. So I think that now I thank you for your kind attention. And here you can see my contact, my social contact, and my email. If you want, you can take a picture here of this email, and let's go to answer to the question if we have any question. I have only greetings from a friend of my, Alessandro. Ciao, Alessandro. So if you have any question now, you can print them into the Q&A box. Thank you, Lorenzo, once again. Let's wait some minutes. Don't be shy. We have time to, before the football match, to answer to the question, if you have any, obviously. Otherwise, probably I was very clear, so you have understand everything. So Chin.
Yes.
I think that they had enough time, but there are no questions.
Okay. All right. I'll take the turn. Please stop sharing your screen.
So... Yes, I stop. Thanks to everybody. Bye-bye.